What I thought I'd talk about is around some of the epidemiology, around hepatitis C, evidence of the effectiveness of different interventions, looking at, well, what do we do about if we scale up opiate substitution treatment or needle exchange, or what about treatment of hepatitis C? Can we use that as a tool to prevent hepatitis ongoing transmission? I don't mind being interrupted, if that's okay. If that's the easiest way to do. So if there's anything that and I don't mind being told to hurry up either. And I know I've got to finish. When am I going to finish? For you, got to have lunch at 1:15. Okay. You'll have seen this. This is cirrhosis, liver disease. That's Scotland, that's England and Wales. Probably Wales might be slightly higher, who knows? In UK, and these are other European countries. So we're going up, and most of that is due to alcohol. But hepatitis, viral hepatitis, either through hepatitis B or hepatitis C, is probably the second most important cause of liver disease. Liver disease is the 5th commonest cause of death, and worldwide, perhaps a portion of liver disease is due to hepatitis C. About 350,000 deaths. We've got a liver disease strategy, we've got a drug strategy, so there is an opportunity to then do something about hepatitis C and then onward transmission, preventing liver disease. My one slide about hepatitis, well, I've got 2 slides about. Slide about hepatitis B. Hepatitis B is important for injecting drug users because they can get it acutely. But most people who are adult, who acquire hepatitis B, will clear it. There won't be any chronic infection. Chronic infection mostly occurs in vertical transmission among children under 5, which is why we have this antenatal screening of hepatitis B to discover mothers who are hepatitis B are chronic carriers and then to try and prevent transmission among babies. So when we look at the number of chronic cases of hepatitis B, most of them come from migrants. Most of them come from people born in countries where they've acquired hepatitis B through childhood. So case finding for hepatitis B and prevention of hepatitis B morbidity is all about testing migrant populations. For injecting drug users, it's all about making sure that we get the vaccinations in to prevent acute transmission. Okay?
What proportion of these are infected with Delta?
Oh, God, I don't know. Sorry.
Okay.
It usually comes together,
Yeah.
so sometimes exacerbates it. Yeah. There are different, well, I won't go into that, it doesn't matter. The Department of Health and hepatitis B charities unsurprisingly argue about how many cases there are. But for hepatitis C, which we'll now concentrate on, we've got a pretty good idea of how many people are infected with hepatitis C. And this fuzzy diagram here gives you the range. So where it's darker, we think it's we're more certain. So around 200,000 people in England and Wales are infected with hepatitis C.
Is that like 1 in so many?
It's about 0.6% of the adult population. And most of them are acquired the hepatitis C through injecting drug use. We know the reason why this is bigger is because we know less about ex-injectors than we do about current injectors. So they're more uncertain. But the key is that it's a common viral infection, maybe 200,000 people. It's not 1 million, as some people claimed 5 or 6 years ago, but it's still a large number. And perhaps 85% of infection is acquired through injecting drug use. So if we want to prevent liver disease through hepatitis C, we have to deal with hepatitis C among injecting drug use. Now there's been some discussion that these estimates didn't count hepatitis C transmission among different ethnic minorities populations, because they can also acquire it abroad. Egypt's got very lots of hepatitis C, and in Pakistan and India there's some risk if you go and have treatment there of acquiring it through medical practice. But when we looked again and divided up the other risk groups into those that might be white or from other populations, the number didn't get any bigger, but basically perhaps 40% of the non-injecting routes are are in migrants. So again, there's a reason for case finding in migrant populations to look at hepatitis B and hepatitis C. So in the UK, then maybe 90% or more of Hep C is transmitted through injecting drug use, which makes it even more important that that's our core group to do prevention with. Okay, so let's look at some evidence of intervention effectiveness. If you looked at systematic reviews 2 or 3 years ago, they would say the evidence for the needle exchange or opiate substitution treatment could prevent hepatitis C was weak or insufficient or non-existent. That's not because just because we didn't have the studies. There were no trials and lots of little studies that didn't have any effect. So we pulled data across the UK, including Wales, so London, Wales, Glasgow, so didn't do Northern Ireland, don't know why. So let's have studies with different levels of hepatitis C. So what's interesting about hepatitis C among injecting populations is that there are some areas where Hep C is low, and it's certainly in Wales, areas of Wales where the injecting population may have 20% Hep C. Now that's important when we think about prevention and treatment, because actually the lower your Hep C is, the easier it is to clear it out. And we've got different levels of incidence, where a couple of sites, Bristol and London, the incidence was about 40 per 100 person years, or 40% per year, which is massive. In other sites, it was all about 10% per year. But 10% is, I mean, it doesn't sound very, well, it is a lot, even though it's, relatively speaking, modest.
Could the low numbers be due to less number of screenings happening as well?
Oh, sorry, of course. So these are all surveys of injecting drug users, either cross-sectional surveys or longitudinal surveys, where they've measured incident cases of Hep C and have also measured exposure to different interventions, whether that be methadone or needle exchange. And so we pooled data across these sites. And if I show you one example, maybe you don't want to see that. Anyway, I put that in because there's Wales. There's Wales. So this sort of pulls the effect across the different studies, and you get sort of this way means opiate substitution treatment, methadone, reduces the incidence of hepatitis C and reduces it by over a half. And the reason why we had trouble before is that if you look at these, this is no effect. All of the studies we pooled, apart from Wales, were too uncertain. It's only by pooling the evidence that we get some kind of real effect. And so when we put it together...
Excuse me, you said that was due to methadone replacement.
Yeah.
Well, what about, could it be due to an affected needle exchange in areas and nothing at all to do with the methadone replacement? Okay,
well I'll show you needle exchange as well. So that was when we looked at people who were on methadone versus people who weren't on methadone, and looked at how, what the risk of hepatitis C was between those populations, we could see that it was reduced by half. When we looked at people on high coverage needle exchange, and we defined that as when they gave us the people gave us the data saying that they had as many needles from a needle exchange as they were injecting at that time. So if they were injecting twice daily, they had that many. If they were injecting weekly, they had that many. So that was our measure of exposure to needle exchange. And it's different from the literature. The literature often looks at, do I go to needle exchange? Yes, no. If you look at those studies, it looks like needle exchange doesn't have an effect on hepatitis C. In fact, some studies suggest that going to a needle exchange means you're more likely to be infected with hepatitis C. But it's just due to confounding. So we wanted to look at a proper measure of needle exchange exposure, and that's why we looked at high coverage. So when we look at people on high coverage needle exchange, so they've got 100% numbers of syringes per hour they're injecting, or less than, we find, again, that the Hep C risk, the Hep C incidence is reduced by about half. If you're on both opiate substitution treatment and needle exchange, your risk of hepatitis C is reduced by 80%. So that combination. And some of that is due to when people are on opiate substitution treatment, they don't inject. So they really are at genuinely little risk. But even if you're on opiate substitution and you inject, as long as you've got access to syringes, you can reduce your effective.
Don't you think that's going to be highly skewed by access to testing, though?
This isn't voluntary testing, these are surveys. These are studies where we've gone out, recruited injectors, either followed them up or used a dry blood spot test, which will tell us whether or not their infection is in the last 50 days. So people who are tested negative for Hep C antibody, but positive for the PCR, so recent infection. And so we can therefore relate the information on the exposure to an intervention, whether they've had high coverage needle exchange or opiate substitution treatment over that risk period. So we're genuinely measuring the difference in the estimate of the incidence. It's nothing to do with name testing.
I can say that on those figures, it doesn't make any sense to me, because the people who are on methadone are only on methadone for a short period of their needle injecting career.
Sure. Yeah.
So how they can be at half of the level of the others doesn't make any sense.
Well, we will come on to that. You've hit a problem. Not a problem with these data, because we're looking at what's the risk of Hep C incidence if you're exposed to that intervention. And we're saying if you're exposed to that intervention, your risk of Hep C is reduced by half. If you're exposed to both high coverage needle exchange and opiate substitution treatment, it's reduced by 80%. There's no issue around that. The difficulties you're alluding to is, well, if you've got 10 years of injecting, how do we guarantee that you have opiate substitution treatment and high coverage needle exchange for sufficient length of that time to reduce your Hep C for the long term? So we'll look at that.
Some clients do have long-term prescribing.
Yeah, they do. And this is an issue, in a way, provided by this diagram. This shows prevalence of hepatitis C in England and Wales among serial samples of cross-sectional samples. It's public health surveillance data, taken up to 2006. This is Hep C in people who've injected for less than a year. And what we find is that, there was a decline in risk. There was a decline in Hep C during the 1990s, but since then it's been pretty stable, and if anything, it might have increased again among recent initiates. And this is despite over 20 million syringes distributed annually, 5-10-fold increase in methadone prescribed over the last 10 years. So we've got a lot of coverage of good interventions. We know that when people are on those interventions, their risk is reduced, but we're not seeing yet a big observed changes in the prevalence in the population, which is the issue that you're saying, well, what does that mean? Why is that? Well, partly it's because, and this is a model done by a colleague of mine, Matt Hickman, partly it's because people circulate, as you know, from being on opiate substitution treatment in high coverage needle exchange, then going off opiate substitution or going off high coverage needle exchange. And as they circulate between those risk states, obviously their risk of hepatitis C changes. So what we wanted to do is to look at, well, what would happen if we scaled up opiate substitution treatment, if we scaled up needle exchange, to see what would happen on long-term impact on hepatitis C in the population. Because we haven't seen an observed effect now, but maybe that's because we just need to scale up more. So we look at a model, and now this is based on the rough estimate of how much Hep C chronic hepatitis C there is in England and Wales, which we said about 40%. It's also conveniently the same as Bristol, but I realise it's not really the same as Wales, but let's forget that for now. And what we can say is that without the current levels of intervention we've got at the moment, we would be in a much, much worse situation. So coverage, so needle exchange and opiate substitution treatment have prevented a lot of infections. Without them, chronic infection would be 65%, nearly 70%, and that's chronic infection. That would mean antibody positive, because remember, about 25% of people who are antibody positive have cleared the infection. So antibody positive would be over 80%, which is what we saw in Glasgow and in some cities in the early 1990s, where virtually everyone had been exposed to hepatitis. So we've averted a lot of infections. But to reduce it further will require quite a lot of scale-up of interventions. If we scale up from 50%, say, interventions to 60%, we get very minimal change. And it's only if we scale up to 80%. Now remember, think about this, it's 80%. This is 80% of your injectors are on opiate substitution treatment or on high coverage needle exchange for 10 years. Then we might be able to reduce it by about a third or nearly a half. So we're in the situation where we're averting infections, we've prevented hepatitis C, but it would require a massive effort.
Did you model scaling down in the ICD?
Well, in effect, this is scaling down.
Yeah. That's just completely without it.
Yeah, well, yeah, that would be scaling down over the next 10 years. We would just go up. Yeah. I mean, there's no... Opiate substitution treatment and needle exchange are effective at preventing Hep C. It's just when we're trying to create a substantial decline, they need something else. Perhaps we've achieved what we can currently. So that's why we want to look at something else, and what we want to look at is, or what about Hep C treatment? There's a lot of attention now given in HIV for HIV treatment as prevention. So we want to put people onto HIV treatment early because it reduces their viral load, and if they have sex or they share syringes, they're at much less risk of transmitting to somebody else. Now, for hepatitis C, it wouldn't be about putting, you can cure hepatitis C. So can you, if we treat enough people who've got hepatitis C, can you use that as a way of prevention, as a way of preventing ongoing transmission? At the moment, as I said, antiviral treatment is effective for around 60% cure rate, depending on your genotype. Better for genotype 2 and 3, not so good for genotype 1. New drugs coming, which are better for genotype 1. 5 years' time, even better drugs are on the market, very hideously expensive, but they will be coming. But currently, few people are treated, few active injectors, and we can discuss what active injectors means in a minute or later. I think active injectors is anyone who's injected in the last 3 years. So people can have given up injecting be an opioid substitution treatment, but they're still at risk of relapse. So these people are still, and if you're at risk of relapse, you're at risk of then transmitting on, contributing to ongoing transmission. So currently, few of this population are being treated, perhaps less than 1% who are infected. And some of that is due to perceptions of hepatologists that they're difficult to treat, they don't comply, and also fears about reinfection. Now, the things about compliance is that most studies suggest that actually compliance of people who inject is as good as people who have given up or who were never injected. But they're sort of self-selected samples. So the real consideration must be, well, what about reinfection? What's the point if we're treating everybody and they just become reinfected again? So we did a model that looked at, well, what happens if we scale up Hep C treatment and then see what impact that might have on hepatitis C prevalence in the population. So this is a model done by a postdoc of mine, Natasha Martin. And so basically we follow up a bunch of uninfected injectors. They get infected, they get chronic infection, and then some of those we treat. Those that successfully are cured, who don't give up injecting or don't die from other causes, are susceptible again and may become infected. Those who don't respond, who don't cure, we don't treat again. So what we can show is, well, what if we start putting in Hep C treatment, what happens about Hep C prevalence? So this shows, now although all my things go on to 40%, also look at the 20%, because that's, in I think certainly in the valleys, in some areas of Wales, your population has got 20% hepatitis C. This is chronic infection, remember, so antibodies a bit higher. And what we're doing is we're looking at 3 different treatment rates, where we're saying, well, what happens if you treat 10 per 1,000 injectors, or 20 per 1,000 injectors, or 30 per 1,000 injectors? And I'll show you an example. Where we based it on a population of about 3,500 injectors, so 1,400 of them have got chronic infection. Now, if we treat 20 per 1,000 people annually, that's treating 70 people with hepatitis C per year. We could get, in 10 years' time, we could, in theory, get a 30% reduction in hepatitis C prevalence. It could go down from 40% to 28%. And if we treated at a higher rate, 140 per year, we could more than halve Hep C prevalence over the next 10 years. And we can see the same model projections through time. And the most important thing for those in the 20 per 1,000 here, 20% prevalence, after 5 years, this says how much your reduced hepatitis C prevalence is reduced by. But you could get it almost reduced by 80% within 20 years, and maybe over 70% in 10 years, if you treat regularly. Yes?
So can data allowances for those that don't respond and reinfection rates be modeled into that?
Yes, details. Yes, we should come on. No, very important, what we call heterogeneity. In other words, not everybody will be treated, not everybody will respond as well as other people, and some people are naturally at higher risk of hepatitis C than others. So some people, because they're homeless or they inject crack as well as heroin, maybe have more risk. So what about those lot? And we'll look at that. Not yet, but yeah. So if we look at our treatment of 20 per 1,000, that's again about 70 people treated per year in this population, 3,500. We can get over half reduced in 20 years. So in other words, that treatment, in theory, taking into, if we can guarantee that we're treating people who are at risk of transmitting infection to other people, we can reduce Hep C prevalence. So with opiate substitution treatment and with needle exchange, if we add in Hep C treatment, we probably could make substantial reductions in the prevalence of hepatitis C and liver disease caused by hepatitis C. But, is it cost effective? I hear you say. And again, we did a model. So the front end of the model is the same as you've just seen. It's uninfected injectors or susceptible injectors become Hep C infected, they get treated. And then they either clear, they can get a risk of reinfection, or if they don't, they just we don't retreat them at the moment, although in theory with new drugs we could do later. And we compare the impact of treating injectors with treating a bunch of people who are ex or non-injectors who can reduce their prevalence of hepatitis, we can reduce their future morbidity of their own infection, but they can't affect transmission, but they also won't become reinfected. So we're comparing the costs of treating a bunch of injectors who are at risk of reinfection and those who aren't. And it's given in this quality adjusted life years, which is what NICE has to do. And what we find in populations where hepatitis C prevalence, chronic hepatitis C prevalence is less than 40% or less than 20% or 40 or less than 20, is that treating injectors is more cost effective than treating ex or non-injectors. And it's more cost effective because you're averting future infections. That's where all the benefit comes from. Okay?
Silly question, really. In a career of someone who's an injecting drug user for, say, 5 or 10 years, is there any way of working out the knock-on of how many people they're likely to infect?
No, it's a good question. Yeah. I wish there was. There is theoretically, yes, because you can argue what the... Yes, because you can in theory, what this model does is follow people up from becoming infected and then everyone's at risk of being... But it's not a network model, so it doesn't specifically say, I'm infecting you, you might risk infecting others. But we know that because Hep C transmission is quite high, that there are these going to be these number of people. But the average, we don't know.
Yeah, it's like comparative growth rate compared to...
Yeah, but it's like, say with measles, there's this thing called the R0, which is the number of secondary infections that a one index case does. So for measles, it's about something like 10. For smallpox, it's about, I know it doesn't exist, but it's about 6.
Yeah.
And for hepatitis C, we're not really sure. It's going to be more than... We know it's more than 1 or more than 2, right, because otherwise you couldn't have an epidemic. Yeah. And all of your interventions, what they're trying to do is reduce that ongoing transmission. So and what hepatitis C treatment does is it takes you out of the pool of infected people, not you, but one. Yeah. Takes people out of the pool of infected people who are going to transmit it to others. Now, what's critical is, as you were saying, is that the effect of treatment on prevention will only occur if we're getting the people who are infecting other people. So, and what that depends on often, and this is just showing that it's more cost effective even if you have a poorer compliance. So even if your sustained viral response in injectors is half that of non-injectors, it's still more cost effective. It's irritating for hepatologists, but it's still more cost effective. But this other issue is around the transitions between high risk to low risk. So if there are as long as our population of people who inject do have high risk and low risk periods, do circulate, then actually that heterogeneity, that problem, these estimates are the same because what it means is that you can get someone into methadone for a short period, you can treat them for hepatitis C, then if they leave and they relapse and they go into high risk, they're cleared, it doesn't matter. So as long as, if there is a population of people who are just high risk all the time and will never comply, never get into treatment, then these model projections are underestimate the effect. Go on.
Can I throw you a conjecture on your graphic there, which showed needle exchange being very effective at first, dropping down, now climbing again?
Yeah.
We actually do needle exchange differently now from what we used to do it 20 years ago.
Yeah. 20
years ago, we used to send workers out into the community to find the drug users and get needles to the underground drug users. Now, the onus is on them to come in for needle exchange. So I suspect you're not actually getting to that group that you said there of the reinfectors.
Yeah. Yes, no, I think that's the problem with needle exchange, the problem with open substitution treatment is that they're effective while you're exposed to them. So while people are in contact with sort of syringe exchange and can get enough syringes for injection, then they are protected, the same as if they're in open substitution treatment. But the trouble is, that doesn't happen all the time. That's why people in their first year of injecting are at considerable risk of hepatitis C, that maybe 1 in 5 will become infected at that time, before they then go on to be exposed to other interventions, which is why we suspect you need to add in Hep C treatment. Because that way, even if they become infected, you can cure them. Then, if they go and become risky again, they may become reinfected, but many of them won't become reinfected. So, going back to NICE, so that's like a sort of, because I couldn't talk about NICE. What we're doing in the PDG is looking at case finding, and we're looking at 2 interventions. One which was dry blood spot testing, which was based on a study done, one site was in North Wales, which suggested that if you use dry blood spots, you could increase hepatitis C testing, case finding, by about 2 or 3-fold. And that was done in a couple of prisons as well as some drug clinics. And there's also another study done in Scotland which suggested that if you could get your GPs to take good histories or go through their case notes and look to people who've ever been on opiate substitution treatment or have reported they're injecting and then test them for hepatitis C, you could, or invite them for a test, you could also increase the number of people screened by about 3-fold. So these are the 2 interventions that the NICE group were then doing cost-effectiveness studies on. There's also another one about hepatitis B, which is based also on case finding within general practice, and on, again, looking at the populations that find migrant populations, inviting them to be tested for hepatitis B or hepatitis C. I won't talk about that. But the results are out in June, 5 months actually. But it's based on that same model that you've just seen before about hepatitis C testing. So if people get diagnosed and sufficient numbers of them get treated, then it will be cost effective. It's not rocket science. But case finding is only ever any point if people get treated. So it's all conditional on people going into treatment, even at very low rates. But if that happens, case finding is cost effective.
So you wouldn't advocate, I'm just thinking in other countries where hepatitis C treatment isn't available, you wouldn't advocate case finding there so they could make certain sort of lifestyle changes?
I think the evidence, I mean, they did look for the evidence that that works isn't there. So that would be probably pointless and not cost effective and may be harmful. But that's not the case here. Here we've got treatment, Hep C treatment. I mean, of course, people can, it's still important as a way of introducing harm reduction and behaviour change and thinking about your alcohol, but it all depends on getting people also, not everybody, but a sufficient number into treatment. Now, some of this we've covered already. These are theoretical projections, not observations, and they do depend on things like heterogeneity, and they simplify what the reality is. But hopefully we'll be able to, what we want to do now is collect data from select different sites about, well, how many people have currently been treated, so then we can fit those into the model projections to show, well, how much more treatment does there need to be for you to have substantial changes in the prevalence of hepatitis C. In other words, to sort of work out how far away are we from the number required. The projections from NICE also depend slightly on there being treatment in the community. So because and that's something I think you should be considering, if you're trying to do hepatitis C testing in specialist drug clinics, that's where your patient is, that's where your Hep C treatment should be.
We've got, I think, quite a good model where I'm a nurse looking at harm reduction in nurse report. And we, all our clients are in substitute treatment. We're NHS, and that's the nature of what we do. But we also have a very efficient needle exchange, so I think we tick all your boxes really. But part of entry into treatment with us in their triage assessment is access to viral testing, which I do, and I can then immediately refer into treatment.
Well, can I suggest that you now...
Which I bypass, we don't involve any GPs.
But couldn't you now do the treatment?
We do.
You do? Yeah, HCV,
Ours has to go to Liverpool, which is a bit of a drag, but we kind of...
So you're doing the treatment in your place?
Yeah, it's actually infectious disease nurses.
Exactly.
They actually provide the medication.
I think that's the great model, getting your infectious disease nurses or hepatitis nurses into your specialist drug clinics, so that they can not to test the people, but to treat the people. Because if you use a dry blood spot, anyone can take a dry blood spot.
We're kind of trying, we've really just set up a bit of a better model than we've been using in the past, but we're trying to interact with our Hep C specialist nurses, but we've got a bit of a distance issue. So we are doing treatment, they'll go off to Liverpool, they'll get their regulators interfere, and they'll bring it back to us, and we'll do the blood and do the...
Oh, right, okay. So do they have to keep on going back?
That's the problem, But we've done a lot of support with them in terms of, and the nature of our clients' base is probably such that they're not too pressed about the notion, but we try to support that as much as we can.
I think as you want to scale up treatment, it's fine for the nice people who are compliant and want to go to Liverpool, but that might not...
It's a big barrier to treatment.
It's a big barrier, but that barrier shouldn't, it's not rocket, Hep C treatment's not that complicated.
No.
Most treatment's not that complicated.
The other interesting thing I might add is that they don't know what systems people use. Our computer system that we use, our system that we use to document on our clients is completely unuser-friendly. What's been interesting is that I independently have set up a client database, and I'm keeping my own independent records on a spreadsheet, possibly highly illegally, I don't know. But I've got much better knowledge of who we've tested, how we've tested, and what the consequence was. I'm now referring probably to one person a fortnight.
Well, what we should do then, in Wales as well, is to do this thing, let's see how many people are being treated, put them into our little models so that we can say, this is what we would expect Hep C prevalence to be in 5 years' time or 10 years' time. And then we get an idea of what scale up might be required. And therefore that's the point to engage with local hepatology and saying, how do we do that? How do we manage that? How do we get this number of people in treatment.
I'm not convinced any data you pick up from the DAP, for instance, or from would necessarily be accurate. I think my little data is...
Yeah, I'm not convinced any of the data are right. That's why we use models, then we could... But yeah, okay. Do any other... Sorry, I've overrun. Any other questions or issues or...
Can I just ask about men who have sex with men? Because there's been hepatitis C increases in that. Now, has anybody worked out whether that's because of, okay, HIV co-infection may be an issue, but whether it's down to the type of sexual activity or whether it's down to perhaps recreational drug use and sharing of non-injectable?
Yeah. It's the risk for men who have sex with men is mostly, if not entirely, among those who are co-infected with HIV. And, you know, it's probably due to some kind of blood transmission through sex. It might be injecting or it doesn't really matter. What matters is therefore that all HIV infected men who have sex with men are regularly tested for hepatitis C, which should occur in most gun clinics. And if they're found to be positive for hepatitis C, they get treated. And then some will be reinfected, and then they'll get treated again and again. So I think, you know, yeah, there is an issue, but it is among the small, you know, that population. Whereas, you know, we've got maybe 180,000 people who've acquired hepatitis C through injecting, who are not yet being diagnosed and who aren't yet going to treatment as well. They don't all have to go into treatment at the same time, by the way. Okay, any other issues? You're hungry, aren't you? Yeah. Okay. I'm sorry I overran. Yeah.